I'm really very happy to have a old friend here, Dr. Akasaka, Dr. Tom from Singapore, and Nakamura here, Dr. Michael Lee here. All right, Dr. Akasaka, would you start the first session?
Yes. First of all, it is my great honor and pleasure to be able to back here, and I congratulate Dr. S.J. Park and the organizing committee on their great effort to have an in-person meeting today. So let's start the first session. Dr. May? Yes. I would like to ask the Professor D.W. Park to have a talk about the left main revascularization 2022 guidelines and concept change. Please.
Okay, thank you. Thank you, Professor Akasaka. So first topic is about the left main revascularization and the 2022 and the guideline and the concept change. So this is my disclosure. And the first slide and the interventional cardiology dilemma in the contemporary ischemia trial era. And each time, the new series of PCI trial result is cost neutral or worse versus OMT or bypass surgery. Some interventional cardiology community call for another new trial with a different patient, better stand, more IBUS, more FFR, more follow-up, another trial endpoint. I'm interventional cardiology, but with evidence generated so far, I believe we can safely conclude PCI does not improve survival in patients with stable ischemic heart disease. However, and the PCI maintain key role in acute coronary syndrome or for improvement patient-oriented outcome measure in patients with angina unresponsiveness to OMT or unwilling to too many anti-anginal medication or unwilling to receive invasive bypass surgery. So, and look back the last 20 years, PCI versus OMT for stable ischemic heart disease, there are many trials up to recently, ischemia trial, ischemia CKD, and the Revive the trial, all trial was negative and neutral treatment effect. And the recent ESC presented Revive the trial targeting 700 patients, low ejection fraction, PCI versus medical therapy, no difference at all. PCI or bypass surgery for multivessel disease in Syntax trial, BEST trial, Freedom trial, FAME3 trial, MACE event, always better for bypass surgery. So, and look back the current class 1 recommendation should do revascularization in terms of prognosis. Only one indication, class 1 indication in the recent ACC-AHA guideline and the stable ischemic heart disease, multivessel disease, severe ejection fraction, bypass surgery recommended to improve survival. Just only one class recommendation, and this is based on Stitch 10-year result and the issue before Revive the trial. And the ESC guideline 2 vessel, 3 vessel with the multivessel disease, impaired LV dysfunction, this is issued before Revive the trial, large ischemic burden detected functional testing, more than 10% or abdominal invasive FFR. This is absolutely issued before ischemia trial. We will expect a big change in the next ESC clinical trial. And in terms of symptom, revascularization, class 1 recommendation. So, and looking at the left main disease, and there are diverse spectrum, and until recently, bypass surgery was gold standard treatment unprotected left main disease. And looking at the left main disease, available PCI and the bypass surgery, and the Syntax left main, pre-combat trial, Excel trial, Noble trial, 3 trial shows the PCI would be okay, but Noble trial, bypass surgery was better. And the left main PCI versus bypass surgery controversy, that is Excel controversy, is mortality different. And looking at the primary result published in New England Journal of Medicine 5 year. There was some crossover, hard clinical endpoint. Big issue was raised all-cause mortality statistically higher with PCI rather than bypass surgery. And this survival benefit with bypass surgery rather than PCI is issue in many observational trial, observational study. This is reported in the recent TCT and the large size SCAR registry, PCI versus bypass surgery. They do instrumental variable analysis, primary endpoint, all-cause mortality still higher in the PCI. However, there are many unmeasured compounder. And the recently reported syntax left main 10-year mortality. There is no difference at all, bypass surgery and PCI. Our pre-combat trial, up to 10 year, there was no difference, all-cause mortality. And the individual outcome at 5-year Excel trial, there are issues. This is not powered and not adjusted for multiplicity and not designed for hypothesis testing. And this is the urgent request IPD meta-analysis, and this is published in Lancet Journal in the last year. And our team also involved in this individual patient data analysis. And this trial summary and include syntax trial, pre-combat trial, novel trial, and Excel trial. And the mortality up to 5 years, no difference at all. And 10-year, the report available syntax and pre-combat trial, no difference at all. And the stroke, as expected, much higher with the bypass surgery, and the procedural and spontaneous MI, procedural MI much higher with the bypass surgery, spontaneous MI much lower with the bypass surgery. And summary, and some intermediate low anatomic risk group, left main disease, and no difference at all, primary all-cause mortality, and the bypass surgery associated spontaneous MI reduction, and the repeat revascularization reduction, and the PCI associated lower early instance of the stroke, and the different rate and risk procedural MI depending on definition used. So, and looking at the contemporary left main guideline, ACC/AHA updated guideline, bypass surgery is class 1, and the PCI is 2A, still 2A. There is no detailed classification. This guideline issues after Excel trial. And the 2018 ESC guideline is some recommendation is class 1, and some recommendation 2A, some recommendation class 3. And this is issues before Excel trial. We will expect the next big change based on Excel trial as well as ischemia trial. So there are still unmet need in left main PCI, and this is a very nice review article published in Jack Asher in our team. And still, what is the unmet need? And the PCI versus bypass surgery and the long-term effect bypass surgery versus state-of-the-art PCI, also long-term comparative outcomes, some specific patients, diabetic, and HAP-REP patient, distal left main bifurcation disease is unknown. Also, threshold for regional incomplete revascularization is also issued, and the optimal stent strategy for especially distal left main bifurcation disease is also issued. Optimal antithrombotic strategy is also issues. And a couple of days ago, the very nice paper was published in European Heart Journal, left main coronary disease and evolving management and concept. This is conjoined in the cardiac surgeon and cardiology. And this review article is provided a very general concept and for treatment of left main patient and the general consideration, patient characteristics and comorbidity and the cardiac factor, many factors should be considered. Also, is one of the key points, and this review article is provided, we can provide the 3 modality, and the bypass surgery or PCI, sometimes in patient with significant defined diameter stenosis, 50% patient, we can do OMT without any the objective ischemia and the minimal symptom, we can do favor OMT. And finally, and the graphical abstract comprehensive approach is required, and we consider anatomy, sometimes physiology, and heart team discussion. We should consider hospital resource, also expertise and experience of interventional surgeon, and each merit or disadvantage on PCI versus CABG. We also consider patient preference. This is my last slide, and guideline and concept change 2023 for left main PCI. Contemporary evidence demonstrate PCI was comparable to bypass surgery in mortality and hard clinical endpoint for left main disease. And the PCI and bypass surgery is different intervention performed in different patient by different physician with a different aim. However, two interventions are complementary, not antagonist. The patient occupies center of decision procedure along with heart team. These two central elements are joined across axis, integrate individual interventional surgeon expertise and the host institution resource and characteristics. And finally, through the shared decision making, these comprehensive factors inform the optimal individual patient choice for treatment left main disease. Thank you for your attention.
Thank you very much. Wonderful summary of the left main in PCI at the present condition. So we will have the discussion at the end of this session. And let's move on to the second talk entitled Unmet Need for FFR in Left Main PCI. This will be presented by James An. Yes.
Yeah,
Dr. An, please.
Thank you. Thank you, Dr. Akasaka Sensei. My topic is FFR in left main PCI. In other medical centers, nowadays the left main PCI is increasing. In the late 2009, we implemented the FFR concept in our left main stenting. In such an era, the comparison between the bypass surgery and PCI regarding the clinical outcomes come similar regarding the DSMI stroke repeat intervention in our registry data. Why FFR in the left main disease? Because the first inaccuracy of coronary angiogram to evaluate the significant left main disease. In addition, the lack or the low spatial resolution of non-invasive functional study. In addition, even though small registry data, FFR-guided PCI in left main showed favorable outcomes, which is a significant left main disease, left or right. Based on the percent diameter stenosis, right would be the more significant stenosis, but FFR show that the left is lower than right. Why? If you look into the coronary using the IVUS, because of diffuse atherosclerosis, these left figures show that more higher plaque burden, but the right figures lumen is larger. So the inaccuracy of coronary angiogram to evaluate the significant coronary artery disease has been well known. We previously published that there are a lot of mismatches between the FFR and coronary angiogram, reverse mismatches and mismatches. So particularly left main supplying the larger myocardium. So compared with the non-left main coronary artery stenosis, left main coronary artery stenosis, even though diameter stenosis is less than 50%, FFR could be lower than 0.80. So previously, significant left main disease defined by the diameter stenosis of 50%. Based on this definition, the comparison between surgical and medical treatment show that the higher mortality in the medical treatment for the left main disease. Even in the recent era, to compare the bypass surgery versus the PCI, definition of significant left main disease was the diameter stenosis of 50% in our pre-combat trial. The Excel trial showed that more than 70% left main stenosis by visual estimation, and between the 50 to the 70% plus IVUS lumen less than 6 or FFR positive. So this is very unclear. What is the significant left main disease requiring revascularization. Actually, nowadays, left main disease is only one single subset favoring revascularization in stable angina population. In addition, look at the diffuse right and left coronary disease with the left main stenosis. Sometimes thallium specs show the negative because of balanced ischemia between the left side and right side. Another example, the 76 effort chest pain treatment test stage 4 positive, but when you took a coronary angiogram, intermediate right with the RCA stenosis and left main disease, which is culprit. In this case, if you measure the FFR is lower in right with the RCA, but the FFR is above the 0.80 in left main disease, so you can avoid the unnecessary complex left main stenting if you measure the FFR. In addition, although very small registry data, the FFR guided decision making in the left main coronary stenosis show the long-term favorable outcomes. So far, 6 registry data, I combined all instances of death, cardiac death, MI, TVR base rate, compared with the other left main random trial registry data, differed left main disease showed the favorable long-term outcomes. Recently, using the IFR, showed that the deferred left main disease deferred by the IFR also showed the long-term favorable outcomes. What is the technical issue to measure the FFR in the left main disease? When there is osteal disease, you have to be careful to measure the FFR because of guiding catheter engagement. You have to disengage the guiding catheter, you have to measure the FFR because guiding catheter engagement make a significant error to measure the FFR. In addition, for the left main bifurcation stenosis, actually, the left main bifurcation disease is actually diffuse disease involving the left. More than 90% of bifurcation disease involve the circumflex and LAD as well. So if you we recommended you that measure the LAD FFR and circumflex FFR both. But practically, if either FFR is positive, we have to treat left main bifurcation because this left main bifurcation is a single disease unit. We cannot separate treat it. Practically, I would like to measure the LAD FFR first. In addition, the left main disease is not frequently associated with the downstream disease. Our pre-combat trial showed that left main plus triple vessel disease is 41%, left main plus two vessel disease is 32%, isolated left main is only 10%. So when you measure the FFR, if there is a downstream disease, if you insert FFRY like this, left main FFR could be false negative. In this case, left main FFR could be false negative, false positive. So the Bill Ferron published human experiment studies. He measured the left main FFR in the circumflex. So he measured two stenosis, left main LAD. He evaluated the impact of LAD stenosis on left main FFR. So unless downstream stenosis, that is LAD stenosis, unless it's very significant. What is very significant? Less than 0.45, its impact is very mild. Particularly, left main FFR is more than 0.85. Every FFR of left main is above the 0.80. So in addition, we can apply the concept of tandem lesion using the pressure wire pullback. There is two stenosis, the ostial stenosis and the proximal LAD stenosis and mid LAD stenosis using the pressure wire pullback. FFR is 0.77, 0.90. Pressure difference bigger in distal. So I put the stem first distal, measure the FFR. The FFR is 0.84. We can differ the proximal intermediate stenosis. So we have one concern about the big side event when you apply the pressure wire pullback, the tandem lesion assessment. We made some simulation studies show that the impact of big side events are complex on delta FFR is about less than 0.02 or 0.03. So this number may be below the clinical significance. And how to treat the left main disease by PCI? Simply, we can classify the Osgood-Schefter disease and bifurcation disease. Osgood-Schefter disease, we can put the stent, very simple. But if you use the IVUS, you can implant the bigger stent. How about the bifurcation stenosis using IVUS? Depending on the circumflex ostium disease status, you can select the two stent or a single crossover stenting. This is LAD-FFR. LAD-FFR is 0.68. The circumflex intermediate, but I decided to do simple crossover stenting. And then final angiogram show the pinch the circumflex. I'd like to measure the FFR before further treatment because the functional jailing means the FFR below the 0.80 is only 7% if you do the simple crossover stenting. In addition, based on our registry data, final catching balloon dilatation did not improve the patient outcomes. Rather, the increase the some event in the left main stent. So I measured FFR is 0.82, so I deferred. So Keimyung National University teams published data. If a circumflex FFR is low, high, the 5-year outcome is low. But the one problem is even though FFR is high, at 5-year, about 10% or 19% event occurred. So we have to solve this problem in the future. So for the true bifurcation based on the DK Crush 5 study, I would like to the two-stent upfront the two-stent technique. I don't care any two-stent technique. After two-stenting implantation, I would like to measure the FFR. I would like to measure the IVUS according to this criteria. I would like to optimize the stent result. In the 2018, one additional left main evaluation was embraced by the guideline. IVUS, minimal lumen area, different from the non-left main bifurcation. Left main bifurcation, minimal lumen area, our Korean data show the cutoff is 4.5, less than 4.5. Accuracy is 80% with FFR positive in patient with 112 population. So this is my last slide. What is the unmet need for FFR and the left main PCI? My talk is very straightforward according to the FFR concept, but the concept of FFR used in left main disease has been evaluated in relatively small observational studies. I think the large randomized trial or large prospective studies would be necessary. In addition, because of the complex nature of left main stenosis, operators should be careful to measure the FFR and interpret the result. Thank you for your attention.
Great. I stop. So we're going to move next subject. Okay, optimal minimal stent area for the main crush technique, new criteria from Asan Medical Center. Do Young-gang from
Yeah, thank you for your kind introduction. I am Dr. Do Young-gang from Asan Medical Center. Today I will talk about the optimal minimal stent area for left main crush technique, a new criteria from Asan Medical Center. This is on unpublished data, but was presented at TCT this year. I have nothing to disclose. There are various techniques of the two-stent, and in large randomized trials, in pre-combat trial, more than 50% of the patient received two-stent technique, and the major was crush. In Excel trial, about 1/3 of the patient received two-stent technique, and the major was the T-stenting. In European Noble trial, 40% of the patient underwent two-stent technique, and the major was culotte. And we already published the famous left main IVUS MSA criteria 10 years ago. It was the rule of 5, 6, 7, 8. That means that if the circumflex ostial stent area is more than 5, and LAD ostial area is more than 6, and the polygon of conference area more than 7, and main area is more than 8, then the revascularization rate was less than 2% in those population. The data was based on the 400 patients underwent left main PCI, but the patient underwent 2 stents was about 100 only, and the patient underwent 9 months follow-up angiography at the time. So we updated those patient data with a longer term, more than 5 years clinical outcome. From 2005 to 2019, 479 patients underwent upfront 2-stent technique for left main unprotected left main bifurcation disease. And we selected 292 patients who underwent 2-stent PCI with the crush technique and completed post-stenting IVUS images, both LAD and circumflex pullback. And we measured the minimal stent area at the area of the distal left main from the main bifurcation to 5 mm and LAD ostium to 5 mm and circumflex ostium to 5 mm. And minimal stent area at that region was used as the key predictors. And this is a distribution of the minimal stent area. The median number of the IVUS measured minimal stent area was 5.8 at circumflex, 8.0 at LAD, and 10.8 at distal left main. As you can see, the number is bigger than our previous value. One would be the updated and more the educated operator that tended to achieve the bigger lumen area, and two would be the better skills and the techniques. And we performed the ROC curve analysis to predict the clinical outcomes. At left main, the area on the curve was 0.57 and the p-value was not significant, but the value that predicting the outcome was 11.8 square millimeter. For LAD, it was 8.3, circumflex 5.7, and the AUC was about 0.62 and 0.64, and the p-value was predictive and significant. So this is the relationship between left main minimal stent area and clinical event at 5 years. As you can see, the clinical the relationship is not so strong. But in LAD, you can see that if LAD ostium, the cutoff value of the 8.3, the smaller LAD lumen area was predictive of the clinical event. Circumflex ostial, the clinical prediction was most strong. And as you can see, the p-value of the ROC curve is 0.006, and the predictive cutoff value of the circumflex ostium was 5.7 square millimeter. And we evaluated the major adverse cardiac event and all-cause death by the minimal stent area. The small left main area patient had a higher tendency of the clinical endpoint, but not statistically significant. And the patient with a smaller LAD area showed significantly higher rate of the major adverse cardiac event and all-cause death. Circumflex also showed similar tendency. And then we performed the under-expansion incidence by the left main segment and outcomes. In group 0 was that LAD and circumflex was well-dilated patient. And group 1 was that LAD and circumflex, one of two was dilated and one was under-dilated. And group 2 was that LAD and circumflex was both under-expanded. And the patient was about 1/3 in each groups. And the incidence of the under-expansion of the left main segment was well related to the clinical outcomes. The red line is that the patient with the LAD and circumflex both under-expanded. Those patients showed significantly higher major adverse cardiac event, 23% at 5 years. Also, all-cause death was also higher in those population with the 10.6% mortality in 5 years. Myocardial infarction was similar between patients, but target region, the left main bifurcation, revascularization was higher in under-expanded patient to 13.5% at 5 years. So let me conclude our new criteria research. In patient underwent left main upfront tooth stenting with the crush technique, the stent under expansion in the LAD ostium less than 8.3 square millimeter and circumflex 5.7 square millimeter ostium were significantly associated with a risk of higher 5-year major adverse cardiac event. And patients with the stent under expansion of both the LAD and circumflex ostium showed the highest rate of 5-year MACE and all-cause deaths. So, obtaining a sufficiently large minimal stent area could be pivotal in preventing adverse clinical events. Therefore, operators should make the best effort to achieve a sufficiently large minimal stent area under IVE's guidance. Thank you for your attention.
Great. We're going to discuss in detail in the later. So we're going to move how to manage left main instant restenosis (ISR). So Dr. Sunao Nakamura from Japan, please.
Thank you very much, and really appreciate the kind invitation and congratulations, Complex PCI 2022. As actually managing left main ISR, there's no nautical chart, no map in this area, in this sea. No strong evidence, no default strategy, but we have some. Mortality after TLR of the left main stent failure is high. This is Professor Castellacci. And this is maybe, I think, a failed registry. Drug-resistant restenosis and left main PCIs, maybe I think we can manage by the PCI. This is Antonio. And also Antonio group show the impact of the prognosis is closely related to clinical presentation and the extent of coronary disease, and also the Korean. DCB also effective. I think these are the elements to consider: clinical presentation, location of ISR, evaluation, characteristics of ISR, and the selection of appropriate devices. Clinical presentation, maybe acute heart failure, diffuse ISR in left main. Maybe we should consider some supporting device. And need high grade skill, maybe quickness, need precise evaluation of the content of the ISR. Evaluation of the ISR, position of ISR, pattern, maybe imaging device, and evaluation of the characteristics, and high grade skill also, supporting device. We have some workspan pattern of the left main ISR, that this is the chart. And also we have a lot of the developing device and DCB. We love them. This is a case of actually 2005, a V stenting with a cipher stenting. Surprising 10 years later, we have some severe stenosis of the left main bifurcation area patient back to the hospital with unstable angina. This kind of case, we need a quickness. So LED stenting and a pot and a KBT and the DCB in a circumflex. And this is final. This is okay. This is also the unstable angina. Left main severe diffuse instant restenosis, LED and circumflex 4 years after the TAP stenting. And also quickness, LED stenting and the DCB KBT. Another 4 years, okay. This is also okay. This is a case of very severe left main trifurcation lesion, 70-year-old gentleman, and using most of T stenting in this case, and then KBT, final angio, looks also okay. But unfortunately, patient back because of angina, but this is a stable angina to block the circumflex. Actually, I'm a professional, the CTO man. I can negotiate this very quick circumflex ostium curve, and then wire pass, and then ballooning, and then DCB, KBT, and this is a fine angiogram. We can do that. This is a case of left main bifurcation area, the severe diffuse region. This case, LED stenting first, And then, I don't like to do the kilo-stenting, but in this case, we do kilo-stenting. And then 6 years later, we have a restenosis, only the surface area. Stable angina, only surface area diffuse ISR, and check OCT. If you look at the OCT image, actually the fibrous and calcified pattern are very concentric. Then, using rotation atherectomy and actually the DCB, and this is the final result. This is a very educational case. I learned a lot of this case. Actually, this is from the beginning very simple LED ostium, just a stenting, and then my pot, and then maybe I think no cavity. 9 months later, surprisingly, a patient back with acute heart failure, diffuse incident restenosis. Very surprised. IBP at that time. Now we have Impera, but at that time we have just IBP and using IBP. And just a stent in the sarcophagus and cavity and DCB. This is okay. But after that, maybe I think 1.5 years later, to second acute failure, this is quite not good. Actually, at that time, we need to send surgery, but at that time, the patient refused the send surgery. And my young junior, this is an emergency case. Anyway, unstable angina. And we need a skillful operator, need a quickness. And checking OCT, very concentric, and fibrous and calcium pack, the both LED in a sarcophagus. And my junior, brave enough to do the rotation atherectomy in both LED and sarcophagus. So maybe I think we should use the implant in this kind of case. So because of we know that the multiple stent makes the DCB less effective, so we really want to avoid double stenting. So at that time, this rotation atherectomy, this is unfortunately patient survive. But maybe I think at that time send surgery. This is the case of left main diffuse incident restenosis only the circumference. This is 10 years later. 10 years later, the circumference diffuse incident restenosis and check OCT. And then we can see the very concentric, the fibrous and calcium plaque and around this area. And maybe I think some operator bias, but we have some opposite to the carina, very severe. We can see some calcified plaque. So at that time, takes orbital atherectomy, diamond back, and timing of the just pull back. Because the rotation atherectomy may be difficult to ablate that kind of area. Diamond back and DCB. And this is the final result. This is very quite interesting after V-stenting, under 1.5 years, restenosis. At that time, we really want to avoid double stenting. And fortunately, we have a very soft plaque in this upper area. So take a DCA. From the left main to the LED, and the left main to the sarcophagus, and the plaque area reduction of 90% to 40%, and then just the DCB. So we could avoid a double stenting. But this is a very specific case. This is a case of very unique left main ostium, neoantimal hyperplasia, and the position is very unique, bottom of the left main. And in this kind of area, it's very difficult to debulk by the rotor. So take orbital atherectomy. This is OCT, fibrous and deep calcified lesion. And then using diamond back, using a guide wire bias. And then, so actually we can debulk the some part. And then this is important, additional vessel preparation using a cutting balloon and NC balloon, and then stenting. And then this is the final. Should be okay. Finally, calcified nodule. This is the biggest enemy for us. This is the case of the left main ostium area. We have a calcified nodule. Actually, at that time, we use the IBUS and we can see the stenosis with the calcified nodule. Then at that time, using a Diamondback, we could see the lesion modification with a Diamondback, and then high pressure cutting balloon. Understand? Looks okay. MSA more than 10 millimeter square looks okay, but unfortunately, patient back just 1 year, and then calcium nodule again. So we learned that's a previous case. So at that time, this case, we sent surgery. Actually, this is true. I learned from him a lot. In this 15 years, this is a collection of the famous quote by Antonio. Mortality of TLR of the left main is very high. So should pay close attention to maximum your PCI techniques to avoid restenosis, of course. Impact of prognosis is strongly related to the clinical presentation, extent of the CAG. So brush up your skill to the limit of you. Good enough, should be good enough. Strategy of left main ISR should be personalized. Depend on the patient clinical presentation, region, location of the ISR, region morphology, and maybe mainly the selection of the best selection of the devices. Thank you very much for attention.
Thank you. Right, so we have almost 20 minutes of discussion time. So it's very exciting discussions from any panelist. Michael Lee, all right? You're gonna be up first.
Dr. Nakamura, wonderful talk.
Oh, thank you.
Your last slide showed that Dr. Colombo said mortality rates for ISR to the left main is high.
Yeah.
Dr. Dugwood Park presented that there's no benefit with routine non-invasive assessment for ischemia after PCI.
Wow.
What is your diagnostic paradigm for patients who have undergone left main PCI for ISR to assess for secondary patency?
First of all, maybe I think 30-40% case patient above because of the maybe unstable. And that kind of case, of course, we want to do the PCI because of the patient. In a case of a stable, we always think, and this is maybe I think a Japanese patient philosophy, some kind of the thinking way. Maybe they want to avoid bypass surgery. So consult us. And then maybe I think we have a lot of the device. So we always thinking, and then for finally, even unstable, even stable, maybe I think in the most of the case, choose PCI. But I think we should consider more.
How about if you're asymptomatic? Let's say at 4 months or 6 months, would you do a functional test? Would you do a coronary CT angiogram?
Okay. So first of all, because of the Takeshi Kimura, he's a very great intervention cardiologist in Japan. He did a lot of the clinical study. And then, so currently in Japan, we just checking just 1 year. And then after that, we don't do the regular routine angiogram. So the patient, if the patient is a no symptom, we don't touch.
I was under the impressions from the American Heart recommendations is that you can consider a non-invasive stress testing 2 years after percutaneous revascularizations and 5 years after surgical revascularization to look for ischemia. But after that, if patient is asymptomatic, there's really no benefit in doing any sort of a non-invasive test. But my take about Dr. Nakamura's talk here is that, when you have a stent failure involving the left main, I think the
it is not the matter of whether we can actually achieve a good short-term results anymore by doing a repeat percutaneous revascularization. It's a long-term prognosis that arises out of this stent failure that we really have to be mindful of, that can we afford these patients to actually come back with a recurrent restenosis of the left main having failed the first time. Unless it's such a low-risk thing, certainly I think the discussions really have to be on something more definitive, like a surgical revascularization when you have in-stent restenosis in left main, in my opinion.
You know, given that most ISR occurs at the ostium of the circumflex, the question will then remain, is the patient asymptomatic? Is it a large circumflex? Is it a dominant circumflex? So you have some clinical judgment. If the patient has preserved LV function, is not unstable, has symptoms that are possibly controllable with optimal medical therapy, perhaps you could leave it alone. Whereas if the patient is unstable, has or a reduction in ejection fraction, then you have to make a decision. Surgeons routinely do not like to put in just a graft of the circumflex only. The mortality benefit is really the lima. So again, goes back to clinical judgment, taking all these factors into consideration. But given the high rate of in-stent restenosis for repeat PCI after ISR, and perhaps in some cases they present with a reduced ejection fraction, which possibly increases mortality, I think there needs to be maybe a heightened awareness, heightened clinical judgment. And these are ISRs occur pretty rapidly, not at 1 year, but maybe at 4 to 6 months, because it's quite rapid.
Okay. Main interventions, regarding the main intervention, lots of changes during the last, several years. And so simply, DW Bach, would you tell us some data about the, repeat intervention in terms of main PCI cases, right? Single stent or two stents from our data? Simply, just...
So and the looking at the iris main database and still, and even though left main stenting, the patient sometimes presented instant restenosis, and most of the patient is not severe symptom. So, and I don't know exact number, and nowadays we don't do routine the coronary the angiography, and we just do the symptom based check it up the patient complaint symptom. We check it up the whether the left main ISR present or absent. And I think although the left main the ISR was observed, we can do another procedure and using the drug coated balloon or cutting balloon and something like that. I think even though patient some shows the left main ISR, and if you treat the reintervention well, the patient prognosis is not poor. Yes.
All right. I would, ask from to the panelists in terms of during the lots of changes, PCI process, surgery concern, right? Look at this isolated left main disease, including the bifurcation, right? Is there any, difference between the PCI process surgery? Michael, just based on the data and your experience, isolate left main, including the bifurcation disease, right?
Right.
Any difference between the PCI process surgery?
Okay. Let's differentiate between osteal mid versus the bifurcation. If it's osteal mid, perfect.
Right.
Left main PCI, no problem.
No more discussion, right?
If you have distal involvement and your syntax score is still less than 32, I still think it's clinical equipoise.
Right. You mentioned about the syntax score, right? Actually, the high syntax score is related with the concomitant to the other, downstream disease. Right. The meaning is LAD disease, circumferential. If you look at just guess about the main bifurcation, isolated, no, too much downstream disease, we don't need to think about the syntax score itself. Right. And clarification of the syntax score in clinical outcome concern compared with the multivessel disease, in the left main disease intervention, no discrimination power errors rather than the multi-vessel disease. The meaning is high syntax score usually, measured by downstream concomitant disease. Bifurcation disease is only bifurcation disease, right? High syntax score means the other downstream multi-vessel disease concern, right? And so lots of issues after Excel studies, for the main interventions. However, main problem would be, I think, is concomitant downstream multi-vessel disease concern, right? Dr. Bak, okay, you mentioned about the total difference. The efficacy concern is quite similar. However, still, bypass surgery is better than the spontaneous MI, new reason intervention, something like that. All the index, those index would be related concomitant to multi-vessel disease concern. Personally, I think so, right? Even in the Excel study, any randomized study, they did mention about the complete versus incomplete, revascularization issue in remaining, concomitant disease status. And so I think it's lots of bias interpreted, some data, even randomized studies. And so isolated MN disease is not a big deal. The reason why, as an interventionist side, you can clearly understand where big vessels, large diameters more than 3, 5, or 4, you can do. The two-stent is great, even in the LAD diagonal bifurcation, something like that. The result must be good. However, every situations, every physician is talking about, some the other high syntax scores, higher spontaneous MI, et cetera, and so. All right, I got my own insight in terms of a main intervention. So we have to consider, I think it's a main disease is not a surgical disease anymore. Personally, I think so. Even after ischemia studies, you talk a lot in the today's and tomorrow's in terms of ischemia study, that. And then main disease is not a surgical
I
disease
agree.
anymore, right?
Especially if it's not calcified. Non-calcified, if you get a large circumflex diameter, let's say at least 325, but if it's also the angle, there's favorable angles and unfavorable angles, but as a general rule of thumb, in an experienced operator, the case can be done safely and patency long-term for isolated distal left main disease is, I don't think there's going to be any difference in mortality, possibly higher rates of repeat revascularization for the circumflex, but all depends on technique. You have to get a good expansion of the ostium of the circumflex because that's where the ISR occurs, not in the left main body.
I kind of agree that you, Dr. Park, that right now we don't have any randomized control trials. Just looking at the isolated left main. I mean, all the left main trials.
All right,
in the context
ostial
of,
shaft region, isolated
that
main
one's
is
quite
another,
straightforward,
another big deal. Bifurcation is more than 70-80% combined concomitant, the other epicardial artery disease. And so we have to see that multi-vessel disease concern, the other epicardial disease concern, main itself is not a big deal. You can see that syntax study, all the studies of study for the main is good in terms of any, clinical index. And so, however, many, all right, the analytic point of that is we have to focus on the concomitant multivessel. Multivessel disease, we don't have any data recently, in concept of contemporary PCI. How can I say that? In terms of any multivessel disease, they use the old ones. Maybe tomorrow we're going to discuss that. Cypher, even in the bare metal stent, Texas, they didn't use no study at all, right? And they have no idea about physiology, obvious imaging concern, etc., etc. So still lots of issues. Surgery is better. However, we need really, data. So in terms of a new concept and
Right. Yeah, I completely agree your opinion. I think yes, Yeah, left main bifurcation is really the problem. The shaft is okay, right? But even in bifurcation, there are many differences in each cases. So we do not have any clear data to differentiate each condition. And also the result of PCI may not only relate to the stent technique, but also there are multi-factors, right? So at least we have to know the physiology data or imaging data to summarize each condition, right? After then, we can discuss in detail more, right?
Can I ask Dr. Kang of his study? I mean, we all agree that you need to get a good, perfect left main PCI results to achieve the same sort of long-term benefit as bypass surgery. So you have just raised the bar for our outcome here. MSA now for circumflex is 5.7, LAD is 8.3. But these are absolute number. Do you actually consider, there's women who are smaller, body surface area, reference diameter may not be as big as men. So do you actually break down by the body surface area of the patient? You also go by the gender differences in terms of this recommended guidelines cutoff for optimal results?
In this analysis, actually we could not find a significant difference between gender or a BSA. Because the number was small, only 300 patients, and between gender, there was no significant difference at the cutoff value. Can you add one more? Yeah.
Can I do more? So there is two type of criteria. First is a relative expansion. Second is absolute minimal lumen area. So we evaluated the relative expansion of a stent, but the relative expansion did not associate with the patient outcomes. But absolute number only associated with the patient outcome. One more thing is we evaluated the pre-PCI vessel size. If there is no statistical difference between the patient with MACE or without MACE and pre-PCI vessel size and lumen size plaque burden. So I think achieving the certain level, certain threshold, above the certain threshold of minimal lumen area, maybe the affect the patient outcomes. That is a relative expansion. If the vessel size is smaller than our threshold, so if we cannot achieve such kind of minimal stent area criteria, then we have to consider the relative expansion. But the vessel is usually bigger than our minimal stent area cutoff value. So I think we apply the full aggressive pre-lesion modification, post-dilatation. I think most patients can achieve the minimal stent area.
Dr. An, you demonstrated the physiology data, right? But similar to the left main, we do not have enough good reference area in proximal LAD, right? Yeah. Therefore, percent diameter stenosis might be difficult to measure, right? Yeah. So at that time, physiology should be one of the key issues to identify the results of PCI and also the indication of PCI. Do you have any good comparison between physiology and the imaging data in your institution? Because you had lots of IVAS, OCT, and physiology data at the same time.
Great. All right, the data is data. So, Dr. An, would you have to explain the 5, 6, 7, 8, cutoff value? We made it several years ago, right? You made a new cutoff value, right? Long-term follow-up, more than long-term follow-up. Maybe our first cutoff, value would be related with the recent, which is rate, and short-term, repeat intervention, something like that. Would you explain that one? So 5, 6, 7, 8, and 6, 8, 11, something.
Yes, 5, 6, 7, 8 give us very important insight, perspective.
You still work?
Yeah, how
right.
to make a good expansion. So, but based on this number is based on the 9-month instant restenosis rate, and this data includes the simple crossover stenting and various type of two-stent technique. So if we include the simple crossover stenting, minimal stent criteria should be smaller because simple crossover stenting patient, the prognosis would be good. And in addition, the time frame is just 9 months in restenosis. But in this study, we expanded the time frame to the 5-year clinical endpoint. So in addition, only the homogeneous patient with the 2-stent cross technique. That's why we made a bigger minimal stent area.
Simply the bigger the better, right?
Yeah, right.
All right.
Particularly the circumflex
So
ostium.
we don't have the data yet. So could you explain, big minimal stent area we can achieve, right? Do you think is any two-stent technique had a different, clinical outcome, something like that? Load, DK crushes or something like that.
I don't think the stent strategy itself is important. Any kind of two-stent technique, if we achieve the full opposition and full expanded stent, the final outcome would be good. So the how to do good PCI would be more important than how to which type, which strategy, what kind of strategy I have to select. That I think.
So very important message, Michael. If you prefer cooled, right? Sealing chance like a DK crush is the best, something like that. However, whatever we used, finally, stent areas, how much we can get, that is most important predictor for long-term clinical outcome. The reason why is we have to see the IVUS optimizations, correct model position, and maximum stent area. That's it. Whatever, I think so.
Dr. Park, I wanted to get your opinion. Let's say you do a crush and you do kissing balloon inflation, right? Do you want to end the case with pot, or is it okay to do a final kissing balloon without pot? Because some people would say if you do kissing balloon, then you should do pot to make it nice and circular. But if you get a suboptimal result, then you go back and do a kissing balloon, then you have the oval shape in the left main. Does that matter?
All right. Technical issues, we as an interventionist, for the fellowship course is a part, right? Very important. However, ultimately, we have to do two, kissing balloon inflation. In terms of a main part stent area is quite enough. Two stent, 8 atmosphere, sometimes 10 atmosphere, explain two big balloon inflating the main shaft, that is quite enough. Anyways, you're gonna do rewiring, it's more easier rewiring. For that, we need a part, something like that. However, there is not much routine, something like that. If you want to do two stent, finally you want to do the kissing balloon inflation, we can make all those things. So I think so, right? Technical point of view, we have to emphasize, PAR, sometimes the TK cursive or something like that. However, finally, how much, stent areas we can get, that is most important thing.
Okay, so not necessarily the anatomy, whether it's oval or nice and circular, not a big difference.
Yeah. Yeah, still we have lots of discussion. So, but because of time limitation, we would like to move on to the next session.
All right.
Thank you very much.